Thank you everyone for joining for this ADA Diabetes India Symposium. And we have very eminent faculty from the US to be the part of this very, very important symposium. And I will request the AV team to put up the introductory slide of Dr. Sarah. The last session, please. I'm sorry for the technical glitch, Noel.
No problem at all. You're on time. Yeah, actually before time, so don't worry.
Yes. So it is my proud privilege to introduce Dr. Sarah. Dr. Sarah completed her medical degree at Baylor College of Medicine and her internal medicine residency at New York Presbyterian Hospital, Columbia University Medical Center, and her endocrine fellowship training at Massachusetts General Hospital. He is now an assistant in medicine at Massachusetts General Hospital and an instructor at Harvard Medical School. She dedicates her research to improving care of marginalized groups by identifying disparities in type 2 diabetes incidence, treatment, and response to the treatment, and examining the intersection of race, ethnicity, and the socioeconomic deprivation with other risk factors for metabolic disease. And you are doing phenomenal work for the diabetes epidemiology interest group of the EDA. We are very, very grateful to you for accepting our invitation for this talk. And now we will play the talk of Dr. Sarah, then we will have Q&A with Dr. Sarah. Can we have the recorded talk of Dr. Sarah? Right.
Hello, everyone, and thank you for coming to this talk. As mentioned, today I'll be talking about the intersection of genetic and socioeconomic risk for type 2 diabetes. Briefly, I'd just like to mention that my spouse works for a Johnson & Johnson company, and I do receive research support from the American Diabetes Association and indirectly through the NIDDK. So as many of you may know, both genetic and socioeconomic factors have been shown to increase the risk of metabolic diseases, and in particular type 2 diabetes and obesity. However, these factors are often studied in isolation, and the relative contribution of these two factors and the degree to which they may interact to impact an individual's risk are poorly understood, especially in populations historically underrepresented in research. With that in mind, my colleagues and I sought to examine and quantify the independent effects of genetic and socioeconomic factors on type 2 diabetes and obesity in 2 different countries and in people of diverse genetic ancestry. We then sought to assess for interactions between genetic and socioeconomic risk on metabolic disease prevalence. In order to do this, we examined 2 different cohorts. The primary cohort was in the Mass General Brigham Biobank, which is a United States-based biobank including 120,000 individuals, of whom approximately 34,000 had analysis. We examined individuals of European, African, or admixed American genetic ancestry. Those of admixed American genetic ancestry primarily identified as either Hispanic or other race ethnicity. And we included individuals who had their full address available in the biobank, which would allow us to geocode them to a census tract from which we could get area-level socioeconomic information. Our second cohort, the validation cohort, was the United Kingdom Biobank, or the UK Biobank, which includes about 500,000 individuals. We included individuals from the 3 most well-represented genetic ancestry groups, which were those of European, African, or Central and South Asian ancestry. And we restricted to those who lived in England because the area-level socioeconomic measures used in the United Kingdom Biobank vary based on the country that the individual lives in. We had 2 key exposures in this analysis: genetic risk and socioeconomic risk. Our genetic risk was measured using global extended polygenic scores for type 2 diabetes and obesity. A global extended polygenic score is similar to a classic polygenic risk score, except that it includes information from millions of single nucleotide polymorphisms across the genome, rather than just restricting to those who have been proven to have genome-wide significance in prior studies. Our socioeconomic risk measure was at the area level. In the Mass General Brigham Biobank, we looked at census tract level measures of education, income, employment, and more complex socioeconomic deprivation indices, which have previously been published. And in the UK Biobank, we examined the indices of multiple deprivation, as well as their subcomponents, which again examined education, income, and employment. And we also looked at the Townsend Deprivation Index. Our key outcomes were prevalent type 2 diabetes and prevalent obesity. In the Mass General Brigham Biobank, we defined prevalent diabetes based on validated machine learning and clinical algorithms. And in the UK Biobank, we used a validated clinical algorithm previously published. In defining prevalent obesity, we used a combination of those validated machine learning algorithms that I mentioned in the Mass General Brigham Biobank, and also used a maximum BMI cutoff of greater than or equal to 30 in the course of a patient's care. In the UK Biobank, we relied on an enrollment body mass index greater than or equal to 30 in order to define obesity. Our primary analysis occurred in individuals of European genetic ancestry. This was done for two reasons. The first is that in both biobanks, those of European genetic ancestry were by far the best represented, such that those of non-European ancestry represented smaller sample sizes, in which we had less power to examine interactions. The second reason that we did this is that the genetic risk scores we used were developed in populations of European genetic ancestry and have been shown to be slightly less predictive in individuals of non-European ancestry. However, we did explore the same analyses in individuals of African, admixed American, and Central and South Asian ancestry, as I mentioned. We examined multivariable logistic regression models adjusted for age, sex, self-reported race, ethnicity, and the first 10 principal components of genetic variation. We additionally examined for additive interactions by calculating the relative excess risk due to interaction and the joint effect. And finally, we examined several sensitivity analyses, including using individual level rather than area level socioeconomic measures, and looking at ethnicity-specific BMI cutoffs for obesity among those of Central or South Asian ancestry using the World Health Organization's recommended BMI cutoff of 27.5. And in terms of our population, in the Mass General Brigham Biobank, we had approximately 27,000 individuals of European genetic ancestry. Mean age was 61 years, approximately half were female, and about 10% had diabetes, 46% had obesity. In the Mass General Brigham Biobank African and admixed American ancestry cohorts, individuals were somewhat younger, more likely to be female, and had higher rates of both type 2 diabetes and obesity compared to their European ancestry peers. In the UK Biobank, we had approximately 216,000 individuals of European ancestry. Compared to the Mass General Brigham Biobank European ancestry cohort, these individuals were somewhat younger and had lower rates of type 2 diabetes and obesity. And then in the UK Biobank African and Central and South Asian ancestry groups, we had smaller numbers of individuals of who were slightly younger compared to their European ancestry peers and had higher rates of both diabetes and obesity, particularly when using the ancestry-specific BMI cutoff of 27.5 in the Central and South Asian ancestry group. Before we move forward with our analyses for interactions, we wanted to understand which socioeconomic measures most strongly associated with metabolic disease prevalence. And in both Mass General Brigham and the UK Biobanks, we found that singular, simple measures of educational attainment were the most strongly associated with both type 2 diabetes and obesities, and they outperformed measures of income, measures of employment, and more complex indices that captured multiple socioeconomic measures. For this reason, moving forward, our key socioeconomic risk factor represented area-level educational attainment. In our multivariable logistic regression models, which again were adjusted for age, sex, self-reported race, ethnicity, and the first 10 principal components of genetic variation, we found that both genetic risk and socioeconomic risk independently associated with prevalence of type 2 diabetes and obesity. And we saw that there was no multiplicative interaction between genetic and socioeconomic risk in the Mass General Brigham Biobank. When we looked at the UK Biobank and the European ancestry cohort, we again saw that both genetic and socioeconomic risk independently associated with type 2 diabetes and obesity prevalence, and there were very small but statistically significant negative multiplicative interactions in this group. When we looked at absolute numbers, we saw that moving from the lowest socioeconomic and genetic risk quintiles, which can be seen here, to the highest combined risk quintiles was associated with a more than 7-fold increase in type 2 diabetes prevalence in the Mass General Brigham Biobank. Additionally, we saw that that in every single quintile of genetic risk, increasing socioeconomic risk was associated with increasing overall disease prevalence, such that socioeconomic risk had an effect regardless of genetic risk. Similarly, for obesity, we found that moving from the combined lowest risk quintiles to the combined highest risk quintiles was associated with approximately 3-fold increase of risk of obesity. And we saw that within each genetic risk quintile, increasing socioeconomic risk, again, was associated with higher rates of disease. We additionally saw significant positive additive interactions. What this means is that the absolute prevalence of diabetes was attributable not only to the genetic and socioeconomic risk, but also to the combined effect of having elevated genetic and socioeconomic risk. And we are able to quantify the degree to which this additive interactions contributes to risk at the population level, which you can see in this graph. The dark green color represents the proportion of overall disease prevalence attributable to genetic risk in the population. The green, or the light green, represents the total percent attributable to socioeconomic risk. And then kind of the blue-green color represents the amount attributable to the additive interaction of both having elevated genetic and socioeconomic risk. And depending on the disease and the population studied, this additive interaction attributable risk was anywhere from 13 to 21% of overall risk. This additive interaction can be appreciated in another way here. We can see that among those in the lowest genetic risk quintile, moving from the lowest to the highest socioeconomic risk quintile was associated with an absolute increase in disease prevalence of 1.7%. However, among those at the highest genetic risk quintile, moving from the lowest to the highest socioeconomic risk quintile was associated with a 9.2% absolute increase in type 2 diabetes prevalence, such that increasing socioeconomic risk has a much greater absolute impact among those who are also at the highest genetic risk. As I mentioned, we performed many exploratory analyses, including looking at individuals of African and mixed American ancestry in the Mass General Brigham Biobank, as well as those of African and Central and South Asian ancestry in the UK Biobank, which can be seen here on the right. Although the sample size was smaller for these groups, the findings were overall consistent, including the presence of additive interactions, which were seen in the Central and South Asian ancestry group. We additionally performed several sensitivity analyses, including looking at individual level socioeconomic measures rather than area level socioeconomic measures, and found similar findings. And lastly, we examined an ancestry-specific BMI cutoff for those of Central or South Asian ancestry, and found again that both genetic and socioeconomic risk attributed independently to the overall risk. Lastly, around the time that we were publishing this paper, there was actually a very similar paper published that examined the interaction of polysocial risk scores and genetic risk scores in the UK Biobank in terms of their impact on incident type 2 diabetes over a follow-up period. Notably, their polysocial risk score included socioeconomic measures similar to ours, but also included a number of environmental measures, such as pollution, as well as lifestyle measures and behavioral factors. Despite these small differences, they did find very similar findings to ours, where both genetic and polysocial risk scores independently increased the risk of diabetes incidence. And they also saw additive interactions with a very similar scale to ours, where they attributed 15% of the overall diabetes incidence risk was attributable to the combined effect of both polysocial and genetic risk. And so I hope I've shown you in the past few minutes that both genetic and socioeconomic risk factors were associated with metabolic disease prevalence, specifically type 2 diabetes and obesities. I hope I've shown you as well that the absolute increase in disease prevalence with increasing socioeconomic risk is greatest for those who are also at high genetic risk, with anywhere from 13 to 22% of type 2 diabetes and obesity prevalence attributable to the additive effects of both genetic and socioeconomic risk in the population. And our findings were similar in people of diverse genetic ancestries, including those of European, African, mixed American, and Central or South Asian genetic ancestry. Because of this, we believe that interventions to improve socioeconomic deprivation may decrease metabolic risk at both the individual and community levels, and especially among those who are at concomitant high genetic risk. However, more research is needed to understand the impact of efforts to improve socioeconomic deprivation on overall disease prevalence. With that, I'd like to thank my co-authors, and in particular, Miriam Udler and Jordi Marino, who helped conceive of this work, and I'm happy to take any questions at the end of the talk.
Thank you, Sarah, for this wonderful presentation. Can we have the Zoom display here? Can we go switch off the slides? So we have quite a few people sitting here and listening to you. And if there are some interesting questions, we can invite. So I would just like to understand one thing, that your work at Harvard School is really amazing, and you're trying to link the genetic factors with the socioeconomic status. But sometimes it may also happen a person who is not having genetically not susceptible, maybe having a good socioeconomic status. So how do you explain that?
Well, certainly there are other environmental factors at play. One very important environmental factor that we really did not take into account in our analysis is behavior. And in that case, even with the best genetics, even with the best, socioeconomic status, protective features, if your diet is primarily McDonald's, then in that case, you are going to be at higher risk for diabetes than if you were eating a plant-based diet, for example. So there are many other factors that need to be considered. Genetics and socioeconomic status are just several of them.
And did you have Indian patients in your study?
Yes, in the UK Biobank, one of our cohorts was the Central and South Asian genetic ancestry cohort. The way that's defined is based on kind of genetic similarity among groups. And there's, briefly, they create a 3D space or a multidimensional space of principal components. They then isolate populations and define people based on how similar they are. And there was a group that was well represented, that primarily represented people of Central and South Asian ancestry. And in that case, we found very similar results to in the general European population that I presented.
So thank you, Sarah, for your nice presentation. And I think Diabetes India audience has benefited from your presentation. And now I will, if there are, Dr. Rucha want to ask something. Can you please focus the camera on Dr. Rucha, and Dr. Rucha will ask the question. You can come here and ask. Yes.
Thank you so much for a great presentation. My question was, it's a very interesting study. I don't know, there was a recent article, I would say a few years ago in the New England Journal. I don't recall the primary author, but they spoke about the genetics, and also they looked at lifestyle, wherein they studied the ERIC cohort, the Nurses' Health Initiative, if you recall. And then they also showed that even if you had a high genetic risk, if you had at least 2 out of the 3 healthy behaviors they studied, you were able to see a reduction in that genetic risk. I'm just wondering, I know you're showing us this data today, but do you have any other data that is not published yet, which kind of reassures us as South Asian Indians? Because we are not very obese, but we are the thin fat Indians with a very high genetic risk. So I don't know if you have anything else that might kind of make us feel reassured.
Sure. So thank you for that question, Dr. Rucha. And I do happen to know what paper you're talking about. The either the first or the senior author is Amit Kara, who is one of our colleagues here. And what was so phenomenal about their study was that in multiple cohorts, they did find that positive lifestyle factors could in some ways negate genetic risk, whereas those who were at high genetic risk but followed a very healthy lifestyle could reach a point where they were at similar genetic risk or similar diabetes risk, or there was a coronary artery disease, similar CAD risk compared to individuals who had lower genetic risk at baseline. I am not sitting on information about that in particular, but we did see that among those at highest genetic risk, having supportive or protective socioeconomic status did substantially decrease their risk. There was a 10% absolute decrease in diabetes and obesity prevalence. So there is something there. I think the overall story is that genetics are not uniformly fixed, and there certainly are modifiable factors.
So yes, that was for CV risk. And when you say socioeconomic, I don't know if you can further shed light on the South Asian cohort that you have as to, so in that particular study, they also found, as you mentioned, that after a certain amount of risk, at modest risk, it benefited the highest for people with a modest risk factors, but with a very high risk, it did not benefit as much. So the question was, similarly in your study, do you see a correlation as to where this peters off, or we don't see such a huge impact wherein improving even the socioeconomic factors would negate or mitigate the risk, the genetic risk?
So to the first part of your question about our South Asian cohort, so it's individuals living in the United Kingdom who are, in the socioeconomic milieu of the United Kingdom. And we examined a number of different socioeconomic measures, including the UK Biobank has a deprivation index. So we looked at that and then all of its subcomponents. It has an education subcomponent, an income subcomponent, and an employment subcomponent. And of those, we use education as our primary measure because it tended to be most strongly associated with disease. So that is really the socioeconomic measure that we're looking at, and kind of the context that we're looking at it. And I'm sure it behaves differently in different societies, in different areas. So it, in some ways can, and in some ways can't speak to India in particular, I would say. But then to the second part of your question, so we actually did see with the additive interaction that there was greater absolute improvement in overall diabetes prevalence among those at highest genetic risk who had, went from high to low socioeconomic risk. So there's, I think for those people who are at higher genetic risk, the absolute difference we can make on kind of the public health society scale is greatest for those who are at higher genetic risk.
Great, thank you. That's fantastic. Thank you.
Thank you.
We have one more question for you, Sarah. Dr. Amit is here to ask you one question.
Hi, thank you for the wonderful presentation. My question was kind of similar in the context that, when you look at the socioeconomic and the genetic factors, did you look at the family behavior or the lifestyle behavior running in the family, having a positive correlation going along with the socioeconomic factors and the genetic factors? That's one question. And the second is, you see a place of therapeutic patient education play a role, in mitigating these factors?
Yeah. So to the first part of your question, we did not factor in lifestyle factors, and that's a definite future direction for this research. One is to incorporate it as its own risk factor. And then I think the second thing would be to examine it as a mediator of the association between socioeconomic status and disease, to see if it's really like education and health literacy and nutrition education that makes that difference in terms of disease prevalence. But we have not done that yet. To the second part of your question, I'm sorry, can you please remind me the second part of your question?
Therapeutic patient education, do you see a role in these cases?
Absolutely. I think the research speaks less to this, and my experience as a physician speaks much more to this, that giving someone the tools that they need to live a healthy lifestyle can be exceedingly powerful and can, in some cases, reverse diabetes, reverse pre-diabetes, and give someone a much healthier life over the span of their lifespan. So absolutely. Thank you for your question.
Thank you, Sarah, once again for being here. And now I would like to move on to the next presentation. For all the people who are sitting here, just to let you know, this is ADA's Public Health and Epidemiology Interest Group team, leadership team. We have chair, we have past chair, and we have the advisory council members who are all here for this important session. And it is very early morning in the US today, but they all agreed to be with us this evening. So I would like to invite the next speaker, Dr. Serena. And Dr. Serena is assistant professor in the Department of Pharmaceutical Outcomes and Policy at the University of Florida. And she conducts pharmaceutical outcomes research with a focus on improving health equity, both in diabetes treatment use and outcomes. And her research draws on real world data. And her specific interests include electronic health records, insurance claim data, and the AI and machine learning as well. And she's working into identifying heterogeneous treatment effects of pharmaceuticals to promote equitable and precision diabetes care. So this is very, very important. So welcome, Dr. Serena, and we'll request you to proceed with your presentation.
Thank you very much, Amit, for the very nice introduction. I'll share my slides first. Can everyone see my slides?
Yes, we can see your slides.
Yeah, okay. Yeah. Let me see. Yeah, I'll start. Yeah. Thank you very much for having me to present at the Diabetes India 2023. I'm very excited to have the opportunity to share our research through this symposium. I'm an assistant professor in the Department of Pharmaceutical Outcomes and Policy and at the University of Florida. So the presentation title is I Smile, Individualized Intelligent Social Risk Management in Type 2 Diabetes Healthcare. Before the lecture, I would like to disclose that I received consulting fee from Pfizer outside the presentation and the relevant work. My research activities has been supported by several federal funding agencies in the US as well as the Pharma Foundation. The story I'm going to tell today is about the development of a social risk management tool of type 2 diabetes named iSmile. The storyline includes why we develop iSmile, how we follow the learning health system cycle to build the data capacity, develop the machine learning models, and clinical interpretation of our model results, as well as public health implications of such a decision supporting tool. It has been very well documented that type 2 diabetes and its complications disproportionately affect racial and ethnic minority groups and the socioeconomically disadvantaged communities globally. We all know that social determinants of health are conditions where people are born, live, learn, work, play, worship, and age. SDOH has been recognized as root causes of type 2 diabetes disparities. In fact, SDOH accounts for over 80% of modifiable factors that influence the health outcomes of a person with diabetes. As such, type 2 diabetes is a public health crisis globally that must be managed beyond traditional medical care. We have to efficiently address patients' unmet social needs in order to improve health equity and health outcomes of millions of people living with diabetes. The importance of SDOH has been very well recognized, including WHO's SDOH statement. Currently, in the US, many hospitals and practices have started incorporating social determinants of health surveys in their clinical workflow to screen for patients' unmet social needs. However, there has been an extremely low uptake of these existing social risk screening tools. According to data from several healthcare networks within the United States that have adopted SDOH surveys in their EHR system, the overall uptake rate was less than 2%. So why the uptake is that low? There have been many data infrastructure and personnel reasons. I think we may obtain some insights from the survey conducted by Physicians Foundation last year, 2022. Nearly all physicians indicated their patients' health outcomes affected at least one SDOH. Over 80% think the United States cannot improve health outcomes or reduce healthcare costs without addressing social determinants of health. Over 85% of physicians think they have either limited time or insufficient workforce to address patients' social determinants of health that essential to their health outcomes and the healthcare access. Very strikingly, more than half of the physicians reported social determinants of health challenges cause the physicians themselves experience stress and frustration on their daily job. Overall, we identified two major challenges in incorporating social risk management into clinical care of type 2 diabetes. First, the existing screening tools are not automated, making them very difficult to adapt to the already very busy and overwhelmed clinical workflows. Second, there are very limited channels as well as uncleared and conformed information on the means to help patients to address their social risks. Specifically, the evidence is limited and mixed regarding the effectiveness of social determinants of health targeted interventions in improving type 2 diabetes health outcomes as well as identified disparities. Our development of iSmile is to address these challenges. We propose a structured approach to integrate social care into diabetes healthcare. So we believe upstream social determinants of health play a fundamental causal role that can shape downstream medical determinants of health and represent important opportunities for us to figure out innovative approach to improve not only health outcomes for individuals, but reducing the disparities of the population. As I mentioned earlier, we're following the learning health system framework, listed 3 tasks. The first task or the first step is to build data infrastructure. We integrate social determinants of health information into the existing EHR database, including both contextual level, SDOH, like neighborhood deprivation, working this ring space workability, as well as person level social determinants of health, such as education, employment, transportation, and food access. The second step is to develop machine learning models. The first model we developed called polysocial risk score. We put together all the social determinants of health to use this create a polysocial risk score, use this polysocial risk score to identify patients at high risk of adverse health outcomes, such as hospitalizations, diabetes complication outcomes. The second part of the model is to estimate the causal effect of key social determinants of health items on the adverse health outcomes. In this way, we can identify the effective intervention target. The third step is to put everything together into the iSmile to design a platform support clinical decision making. So our data is from UF Health EHR. It's one of the sites of One Florida Plus network. One Florida is part of a PCORnet, a national clinical database network in the US. So in One Florida currently, we have 17 million residents in Florida, 2 million in Georgia, and about 10,000 in Alabama. The mainstream of the database is electronic health record. We do different types of data linkage, including claims data, Medicare, Medicaid, and some private payers claims data. We also linked with immunization data, death index, and other disease registry data. UF Health data is one of the 13 data partner of One Florida Plus network, is also the largest data partner. This is the map of state of Florida. So those blue dots stands for the UF Health care system network. So the first step is to build data structure. In order to incorporate a contextual level or neighborhood level factors, we conducted spatial temporal linkage of our external exosome database to the EHR, where the patient's residential histories. So in our established exosome database, we have factors documented social environment, built environment, and natural environment, a total of over 9,000 variables. So the second step of data infrastructure building is to use natural language processing to extract the person-level social determinants of health information from clinical notes in the EHR. In our current cohort of 11,000 patients, we collected over 1.5 million clinical notes and used the NLP pipeline to extract social determinants, health and behavioral and psychological determinants of health, including economic stabilities, education, healthcare access, as well as lifestyle-related factors such as smoking, alcohol, stress, physical activities. We also now developing pipelines to extract diabetes distress information from clinical notes. So after extracting this information from clinical notes, we do the data harmonization with structured data such as the SDOH modules and the Z code to put together, generate person-level SDOH information in the EHR. Our study population was patients diagnosed with type 2 diabetes between 2012 and 2020 in UF Health EHR data. The study outcome of this study is hospitalization in the 1-year follow-up range. So we selected index data as a random outpatient visit encounter, collect both contextual and person-level social determinants of health before the index date, use this information to predict the hospitalization 1 year after the index date. The first model task is to develop a prediction model and generate polysocial risk score. We use XGBoost by incorporating both contextual level and person level social determinants of health and their interactions to identify patients at high social risk essential to their hospitalization risk. The second model task is making causal inference to use causal AI model. We included double robust learning in the causal forest, estimate the counterfactual effect of key and actionable social determinants of health, identify potential intervention target. Results. This is our results for the polysocial risk score. So in our cohort, including 11,611 type 2 diabetes patients in UF Health EHR, our polysocial risk score achieved a C statistic 0.62 to 0.65, a reasonable prediction utility for predicting 3 months, 6 months, and 1 year hospitalization risk. We put the polysocial risk score in a multi-variable logistic regression. After adjusting for demographic and clinical characteristics, the polysocial risk score explained 22%, 19%, and 36% of increased risk for 3 months, 6 months, and 1 year hospitalization risk. That means by 1 year, the social risk explained about 1/3 of the increased risk of hospitalization. Another 2/3 were explained by clinical factors. So in this bar chart, the x-axis is our polysocial risk score. We categorize by decile, and the y-axis was the actual hospitalization rate. In the top 1% of the polysocial risk score, the 1 year hospitalization risk is 36%, means 1 in 3 people would be hospitalized. Well, in the bottom 5 deciles, the hospitalization rate was 10% lower. So these bar chart suggested a good calibration performance of our polysocial risk score. These are results from the causal estimation of SDOH effect. House instability was identified as a key risk factor contributing to hospitalization in polysocial risk score prediction model. We therefore estimated their heterogeneous counterfactual effect in association with hospitalization risk. The left graph shows patient stratification and heterogeneous effect across subgroups. Based on our model, patient without insurance would bear a higher risk of hospitalization caused by housing insecurity compared to patients with insurance. On the right side, it shows variation of individualized effect of housing instability on hospitalization risk, which means if we put intervention targeting on improving people's housing condition, would be more effective in some patients than others. So then we put everything together to make the iSmile platform. Here shows the initial user interface for the iSmile prototype, developed based on a real patient case, a female 53 years old, white, Hispanic ethnicity. So with the polysocial risk score, the 3 months hospitalization risk is 92, categorized into the high risk class. Then we further break down the 3 months hospitalization risk, identified 2/3 were explained by clinical factors and 1/3 were explained by social risks. So these are the top 5 predictors generated from our polysocial risk score predicting 3 months hospitalization risk. But we all know that the predictors do not necessarily act as causal risk factors. So we re-rank these predictors based on their causal effect associated with hospitalization risk. Then the next step of iSmile is to develop the navigation system to help patients connect the available community resource and the programs to improve their social conditions. Implications and take-home message. iSmile information can be used to support the shared decision-making between the care team and patients on personalized intervention strategies to manage patients' social risk. This project has established the methodological framework and generated real-world evidence for effective social risk management in clinical care. We believe iSmile has the potential to improve health and health equity by integrating social care into healthcare delivery, leading to a paradigm shift in the US healthcare delivery. So this is our study team at UF. We have a multidisciplinary and very collaborative and supportive team, including experts in data science, implementation science, clinical diabetes, machine learning, NLP, and health services research. So that's it. Thank you very much. I'll be very happy to take any questions.
Thank you, Sarina. I think it's really interesting that you're trying to bring AI and you have developed a Polish social risk score. I would like to ask you one thing, that what was the most common cause of hospitalization in these patients in your study?
Sorry, Amanda, can you ask again? I didn't catch it.
I was curious to know that what was the most common cause of hospitalization in these patients in your study?
Most common
Cause of
hospitalization. So that's a great question. Actually, according to our model, the top predictors are individual level social determinants of health. Health instability is one of them, and the financial constraint is one of them. And we have transportation and physical activities. Those are top 3 or 4 risk factors.
So that was one thing, and I can see, yes, Dr. Rucha wants to ask something. Yes, you can ask from there. Please switch on the mic. And I can see Karthik sitting here. Karthik, what are the possibilities? You may be thinking many things before Dr. Rucha would ask. Sure. You can come here and ask.
So my question was just to know that, are you using this on a regular basis at University of Florida? And if yes, how can we access it? Or it's a very interesting tool. Surprising to see 1/3 of the contribution for admission is due to, social reasons or what you've been able to determine. That's pretty exciting. So, and what the cost would be for a hospital to install it. It's more of logistics.
Thank you very much for your question. So we are in the process of developing it as a module can be embedded into the EHR system. And we are also have a conversation with a startup to build the app, can be a part of the patient portal. So yeah, our goal is to develop as a product. Yeah.
Because that would be pretty exciting if this was actually a part of the patient portal where the patients could also see, I don't know if there was a way of saying they put in their steps, also their physical activity scores, and that could also tie in, because I saw you had some of that data in there. But
yes,
it seems to be that the financial, I don't know how accurate, is there a way to determine the accuracy of you said the home instability? How are you determining that? The financial part, I can understand, but the home instability, how was that being determined? Is that such
like financial status, like education, employment information, those information were all collected from clinical notes. That's right. That's not necessarily capture all the most accurate information, but the Polish social risk score for us is a first step screening. So with those information, we already have a reasonable predictive utility and a reasonable sensitivity to screen patients at high risk. That's the initial step, and this step going to trigger a deeper in the conversation between the care team and the physician to collect further social determinants of health information, personalized with the patient's needs. Then that's the second stage of data collection. We're going to use the first and second stage data collection to refine our prediction score as well as the causal effect estimates.
We have one more question for you, and Karthik is here to ask.
Very interesting presentation. A quick question: what's the internal view on how transportable are these models? For example, in which geographies or which social conditions you feel this model can be applied, or will it work only in on the data on which the model has been built right now?
Yeah, that's a great question. So our current model developed based on the common data model of One Florida. Plus, it's a common data model used for PCORNet, a U.S. national clinical network. We're transporting this model to the OMAPS, which is EPIC. Common data model has been widely used not only in the U.S. and many other countries with a similar EHR systems. And transportability is definitely one of the data infrastructure component we're working on.
Thank you.
Thank you.
Thank you. Thank you, Serena, for that talk. Now we can move on to the next speaker. Do we have Dr. Noel with us?
Yes, hi, Amin.
Noel
How are
had
you?
an emergency, Dr. Noel, and we just came to know. We are happy that you are safe.
Thanks.
Yes. So let me just introduce Dr. Noel. Dr. Noel is the chair of Diabetes Epidemiology and Public Health Interest Group of the ADA. And he is one of a very big name in the field of epidemiology. And right now he is very busy because of the Public Health Week, which is going on right now in the US. And our interest group is doing multiple activities. Every day we are streaming and doing something under the guidance of the Noel. I will request him to proceed with his talk, and he will be speaking on the physical activity in the prevention of type 2 diabetes.
Good. Diabet, thank you so much for the invitation. And yes, while Serena was talking, we were evacuated from our building because there's a construction site, there's a gas leak, so I had to cross half the campus and finding a quiet place, but here I am safe, so thanks. On behalf of the Public Health and Epidemiology Interest Group, I really like to thank Diabetes India for the opportunities to be here with you today and to have this space for our interest group, a seminar or webinar, and on 4 different topics that are related, that each of us of the leadership is working on. And especially also a lot of thanks for Amit for all his work within our leadership team of ADA. So my talk is going to be about physical activity in the prevention of type 2 diabetes. This is a picture of the campus, how it looks like when it doesn't rain. So I'd like to go through 4 different contents. First of all, very briefly about type 2 diabetes prevalence and risk factors. Then to talk about what do we know on cohort studies in regard the effect of physical activity in preventing diabetes mellitus. Then we're going to talk briefly about the effect of physical activity in prevention of diabetes, results of clinical trials, and in the end, like how we can implement scientific research into the practice, which means the translational research element. I think we all know that, or we know that the estimate numbers of the International Diabetes Federation that shows like the prevalence of diabetes in the age group 20 to 79 years old. This is published more or less a year ago. And we see especially India also have a high prevalence of diabetes in all the Americas. It's over 9%. In some parts of the world, we have over 12% diabetes prevalence. So as diabetes is very difficult to treat, we should probably put a lot of attention focus on how to prevent it. We also know a lot about the preventable modifiable type 2 diabetes risk factors. On the top, usually it's obesity, central obesity, physical inactivity, and sitting time. And my talk will be mainly focused on the physical activity aspects of physical activity and partly sitting time, but also combining like the aerobic and strength training and its impact on the prevention of type 2 diabetes. But we know a lot of modifiable risk factors, and we should probably work interdisciplinary targeting most of them. So what do we know? The evidence of cohort studies on the effect of physical activity in prevention of type 2 diabetes. Basically, it's not that new. We had evidence already many years ago. This was a study from the Harvard alumni study published in New England Journal of Medicine in 1991 that followed up like Harvard alumni according to their baseline physical activity. So they had like sports played, some people had none, moderate only vigorous, only moderate and vigorous. They also had another variable, flights of stairs climbed and blocks walked per day. So they followed up these alumni and they realized that the relative risk for those who are moderately active at baseline to get type 2 diabetes was reduced by 10%. Those with vigorous physical activity was reduced by 31%. And those who had moderate and vigorous physical activity in leisure time, they had a reduction of future diabetes by 35%. And we see there was apparently a tendency, like a dose response. When they had a look at flights claimed, they didn't find statistically significant differences. However, it seems to be that if you climb 5 to 14 or more than 15 stairs per day, that you have a reduction of diabetes by 25%. Blocks walked was not associated, but what the study also showed is that for 500 kilocalorie of energy expenditure increase, the incidence of diabetes decreased by 6%. And this was known already 30 years ago. And this provided probably first time some baseline information of what's happening. Then there are a couple of systematic reviews and meta-analysis on the relative risk of type 2 diabetes in people with moderate intensity physical activity. And this is one published already more 15 years ago that showed like in total a 17% risk reduction of type 2 diabetes among those who have moderate intensity physical activity. And these are population studies. They also revealed another systematic review by Grönvet about 12 years ago that weight training is also associated with the incidence of type 2 diabetes. We can see here on the left side, it shows the relative risk of type 2 diabetes according to weight training in minutes per week. The interesting thing is, and the important thing is, that already with 60 minutes or 30 minutes of weight training per week, you have almost a 20% reduction of risk of future type 2 diabetes. And if you add like minutes to it, like probably after 120 minutes, we seem to reach a threshold. The additional benefits are probably not that high, but I think for public health purpose, it's important to know even with 30 minutes or 40 minutes of weight training per week, we can have already substantial benefits. What they also did, they analyzed like combination of aerobic exercise with strength training. And they basically revealed, we can see here on the right-hand side, the black dot is those who did not have any weight training, did not meet the recommended recommendation for aerobic exercise, which used to be 150 minutes per week. Then we have those here on the left-hand side who do not in general meet the recommendations, but do weight training. So even with 1 till 59 minutes per week, they had already a reduction of 20% of diabetes. And those who practice or reach the aerobic recommendations, weight training apparently gives some additional benefits in regard to future risk of type 2 diabetes. So this is important for people who maybe are not able to do aerobic exercise. They can do add weight training, and that maybe also relieve some benefits. Another review meta-analysis published 7 years ago revealed evaluated total physical activity and risk of type 2 diabetes, and there basically showed that the overall risk reduction of type 2 diabetes was 35% if people were active. So again, pretty solid the evidence. We can see here the blue boxes, there's not that much heterogeneity. All studies basically revealed the same direction of the association and combined a 35% reduction. That particular study also analyzed several components of physical activity. So we have here in the box A in the upper left corner, they showed leisure time physical activity in type 2 diabetes, a linear dose response analysis per 20 met hours, so metabolic equivalence hours per week, about a 20% risk reduction. Then they also show met hours per week in general in panel B, that similar than strength training, we have large benefits already for small amounts of met hours per week. And then more or less for more hours, it probably levels off. The similar pattern seen in D, of leisure time facility per hours a week. With 1 or 2 hours already per week, we can see large benefits. They also analyzed the intensity of physical activity, so we could see vigorous physical activity in type 2 diabetes, high versus low analysis in panel A. So a 40% almost risk reduction, those who have vigorous physical activity compared to those who do not have. Even low physical activity compared with those who have no physical activity seem to be of benefit for future type 2 diabetes. Then we can see that moderate physical activity had a risk reduction of almost 30%, and even walking, which is an easy form of physical activity, revealed more or less a 20% risk reduction of future type 2 diabetes. And as you can see, the scientific evidence in real cohort studies pretty solid. As we know from research designs, experimental study, they offer a bit more evidence of causal association. And there were several studies that have been conducted on several randomized clinical trials in people with pre-diabetes to see whether we can decrease the onset or prevent or delay the onset of type 2 diabetes. So the very first study was to finish the diabetes prevention study that included about over 500 persons with impaired glucose tolerance, middle-aged adults with a BMI at 25. They were randomly assigned to 2 groups, a control group and an intervention group. And the intervention group consisted of reaching 30 minutes of physical activity per day combined with weight loss. What you can see in the slide is like the people free of type 2 diabetes in the follow-up. And we can see already after 1 year, there started to be a difference between the intervention control group. At 2 or 3 years, the difference was basically the relative risk was a reduction of 58%. Interesting, the study population or the participants were followed up afterwards for more years, and that difference remained even that after the intervention stopped. Changes in cardiometabolic profile in the participants were remarkable. So we see naturally a weight loss, waist circumference decrease much more in the intervention group than the control group. Fasting glucose values, 2-hour glucose values decreased more. We had an improvement of HDL cholesterol, a decrease in triglycerides, and systolic and diastolic blood pressure. So all these interventions had an impact, a large impact on the cardiometabolic risk factor profile that also leads not only to a decrease in the risk of diabetes, but other cardiometabolic diseases. You know, from the DPP, the Diabetes Prevention Program, that had similar results. They published the results about 1 or 2 months later. They had an additional group, the metformin group, and again, the lifestyle intervention group was mainly physical interventions and weight control. But you can see the lifestyle intervention group did much better than the metformin group that consists of 850 milligrams per metformin every day. When they analyzed specifically like the change in physical activity, naturally, there was a large improvement of the physical activity, the metabolic equivalents per hours per week. In the lifestyle intervention group, as it consisted of the physical activity intervention, and metformin doesn't improve physical activity unless you probably put the tablet on the 10th floor and you have to climb up the stairs to get it and coming down. But basically, lifestyle was probably worked much better due to that fact that it included an active component. We also know from the Dajing study in China that analyzed the very similar interventions that consisted of physical activity and other components of weight control. And they analyzed their study according to different intervention group: diet only, exercise only, and diet and exercise combined. And they analyzed separately lean participants and obese participants. You can see on the left-hand side the control group that had the highest incidence per 100 person years of diabetes, and the highest had the obese in the control group, so they did not have diet or exercise. We can see all 3 intervention groups that worked, that decreased the incidence of type 2 diabetes. Naturally, the decrease was bigger in lean individuals compared to obese individuals. But even if you're obese and start with exercise, you're going to have a benefit and reduce almost by half, or by almost 70%, the incidence of type 2 diabetes. And this is important when we talk with people. Sometimes we have people that are obese, overweight, and they think that they don't benefit from lifestyle changes or exercise because they're obese. But evidence shows that even if you're obese and overweight, you're going to benefit. Naturally, you need to be careful how to prescribe physical activity. In summary, we can see that the evidence from randomized controlled trials is consistently showed that type 2 diabetes can be delayed or prevented by lifestyle intervention. We can see here a lot of studies separately analyzed exercise, and relative risk reduction varied remarkably up to 46% of relative risk reduction in people who engaged in physical activity. Also, I'd like to point out a lot of studies that combined physical activity with diet interventions, and we'll talk a little bit more later on that. There's also a study that combined like the effect size of physical activity interventions on HbA1c in people without diabetes, and they consistently show like improvements of HbA1c in percentages up to 0.25 units, decrease of HbA1c in people who are physically active. And yeah, in general, there's summaries of short-term interventions in populations with prediabetes, a screen detected prediabetes followed by intervention. And if they're short 6 to 2 months, the impact of the risk reduction of type 2 diabetes was about 31%. For longer interventions like 3 to 6 years, scientific evidence have showed that the relative risk reduction is about 37% of future type 2 diabetes. So we have the information, and we know that from cohort studies and from randomized control trial that physical activity can delay or prevent type 2 diabetes. Now the question usually is, and it's the last part of my presentation, how the population can benefit. And this is where probably translational research come into actions, how to drive existing interventional clinical practice guidelines, how to implement the guidelines, and then how to evaluate the impact of implementation of the guidelines. The ADA guidelines includes evidence on physical activity and lifestyle interventions on the prevention or delay of diabetes in people with prediabetes. But there was a delay of almost 10 years getting into the guidelines. I'm not sure, I don't know the Indian guidelines. I hope that you have some elements on this already included, and I'm convinced you have. So what did we do in Europe and South America in this intervention? First of all, we developed a European study, the DIA plan, and the main leader was my mentor, Jaakko Tuomilehto, who most of you probably know. And when we implemented the project, we had about 20 centers in 18 different countries in the European Union. In each of these countries implemented the TPS, so interventions of exercise, weight control in people with prediabetes in primary healthcare. So these were not anymore scientific studies, were how to implement interventions we know that work in real life in primary healthcare. I'm going to show the results of one center, the center in Catalonia, Barcelona. In primary healthcare, they had almost 600 patients that were evaluated, and they showed that both individual interventions and group interventions on increasing physical activity and nutritional habits decreased the incidence of type 2 diabetes. The individual interventions are more effective than the group interventions. However, both interventions worked. And when they had a long term and they followed up the patients for up to 4 years, they realized even after 1.5 years or 2 years, already there was a large difference and cumulative probability of remaining diabetes-free between the intervention and the control group. So they basically showed that it works as well in a real-life population. So in a concept of a pragmatic trial, naturally the impact's usually less in real life than in clinical controlled settings. What we did next, then we brought the project to Barranquilla, to Colombia, in the north of South America, and we screen detected people, and we included people, about initially 500 people in 3 different groups: a control group, nutrition intervention group, and physical activity group. The nutrition group had first 6 months of nutrition interventions followed by physical activity interventions, so adding the component. The physical activity group had first started physical activity, and then the nutrition element was added after 6 months. What we basically realized in that study is that we didn't find differences between the control group and the interventions group in 2-hour glucose levels or fasting glucose. The problem was that all groups improved. Even the control group reduced the 2-hour glucose values by 20 milligram per deciliter. And the reason probably was there was a high contamination of the intervention because some members, family members, they were split. One was in the control group, the other intervention group. So it was a contamination of the interventions. There also may be some effects like the heart-turn effect or a lot of diabetes-related activities in that city at that time. However, we think that we showed that we can implement it works, we can detect people, screen for people at high risk of diabetes, and provide lifestyle interventions in a primary healthcare setting, even a country that is very different than European countries, such like lower or middle income country. The CDC had the second ever National Diabetes Prevention Program. It has now probably over 1,600 centers and programs in all 50 states. More than 10,000 coaches have been trained in providing interventions. There's probably nowadays almost 200,000 participants, and a lot of healthcare plans, insurances have included this into their coverages. So patients receive reimbursement if they participate in the program, because they realize it's cheaper to prevent than to treat. The first ever national diabetes program is the one in Finland. The DECO program is also implemented in the whole country, but it's different probably implementing program 5 million people, such as Finland, on a population of over 200 million. And I think I can only imagine the challenge you have in India with 1 billion people implementing diabetes prevention. There's evidence on diabetes prevention in the real world. So having a look at the weight changes and impact. So they basically revealed that weight changes, I think this is a percentage of more than 2.3% combined, which I think has a big public health impact. To conclude, people at risk of type 2 diabetes, they should receive counseling, how to reach the recommended levels of physical activity. Probably a combination of aerobic and strength exercise will be most beneficial. And it also means health personnel who manage people at risk of type 2 diabetes, they should have adequate training skills to advise their patients about physical activity levels and how to prescribe physical activity and have a follow-up whether they reach the levels and what the barriers are. Finally, the Cochrane Library published their evidence-based recommendations that first stating that diet, physical activity, that there's no firm evidence that diet alone or physical activity alone compared to standard treatment decrease the risk of type 2 diabetes. So, however, these two elements combined, diet plus physical activity, reduces or delays the incidence of type 2 diabetes in people with impaired glucose tolerance. And everything is about energy balance. So that's why it's probably changes in physical activity should be combined with change in nutritional habits and caloric intake. Thank you very much for your for your invitation, and I'm more than happy to answer questions.
Thank you, Noel. And let me tell you that we have two marathon runners in the audience. We have Dr. Rucha and we have Dr. J.S. Kumar, who are fitness enthusiasts and fitness freak, and they are diabetologists, leading diabetologists of the country. I will request Dr. J.S. Kumar, would he like to ask something on this? He can come to the dais and ask. And
Good morning, Noel. That was a wonderful presentation. I just was wondering, did you have, I know this is an epidemiological data that which you have presented, any CGM data you have done off late, especially the Europe with Jaco in being your mentor, anything off late, because initial studies were all old data. At that time, CGM was not prevalent, especially that can also help us to know the exercise prescription much better if we have the CGM data. And any hypos you have encountered during the initial training program on exercise in these patients who are already diabetic?
I didn't understand everything probably due to the sound, but I mean, Finland started like with, for instance, physical activity prescription program throughout the countries many years ago, and primary healthcare physicians are trained and they have official prescription documents, and there's some evidence as well from New Zealand on the green prescription of physically prescription. So the effect, what some studies have shown that patients, they increase the physicality if prescribed. Now, for the European project, each center, they were free how to implement the intervention, so, and how to follow up the patients, because it was funded by the European agents like Sancor at that point. They're not interested in research, they'd like to implement. And this had a bit of negative impact on how to build in the research component. However, some of the centers that managed to build in a research component, like the center in Barcelona, also the center in Norway, Finland, and I think Germany. So they showed. And I didn't understand the question on the component that was inbuilt.
I want to know whether continuous glucose monitoring was.
Glucose monitoring. Okay. No, basically what they did in most, as there's in primary healthcare, they assessed an oral glucose tolerance test in the patients. And the first used the FINRIS to identify people at high risk, followed by oral glucose tolerance test. And if they had impaired glucose tolerance, they were included in the analysis. So as there were patients with pre-diabetes IGT, they didn't have continuous glucose monitoring, but they had follow-ups within primary healthcare every 6 months.
Thank you, Noel. I think you have made it very clear that exercise prescription can really help us with the prevention of diabetes if somebody is already having diabetes. And prescribing exercise can definitely improve the glycemic control, as you have shown in various studies. So congratulations for your wonderful work. So we are getting late. No.
See, welcome. See, it's a preventive message from the Big Mac's workplace. So we appreciate. But the problem is translating this message into practice. How do you motivate the cow's potatoes? Because in India, there's one company called Mintra that gives points to motivate you so that your exercise is not only beneficial for your health, it also for your wealth. So such kind of things we could what is that, engage with the corporate, even the drug companies are willing to spend a whole lot of money to encourage at least the medical personnel. So that will put us into the right track. Very best wishes.
Okay, I think it's a very valid comment. I can't hear. All right. Thank you for this. It's a challenge. So I think it's a huge challenge how to implement evidence-based, what we know from basic research, from trials into the population. I think it has the gentleman had a valid point. It's not easy, but that's why we need to work together interdisciplinary and how to blend the changes. And it's difficult, as we have shown, but it is possible. And we have showed in several countries in the world that it's possible. I mean, in India, you had the great study, the Indian Diabetes Prevention Program, that provided a lot of information for evidence-based guidelines all around the world. So, in a different population than the US and European population. And we definitely need an interdisciplinary approach in order to implement it. We need guidelines, and need probably as well help from ministries and having national plans, how to improve physical activity, how to improve nutrition. We have to implement high-risk strategy in primary healthcare, identifying people with IGT, and even cardiometabolic risk factors, and then systematically prescribe exercise and following them up. And we need to probably organize, structure some of the primary healthcare activities and centers, logistics.
Thank you, Noel, for being here for your presentation. And we look forward to see you in Florida as well as San Diego in the month of June. Dr. Rucha, want to ask something? Yes, you can ask.
So I just have a quick question, Dr. Noel. Thank you for that great presentation. To just sort of go along and ask, we all know exercise prevents diabetes, and to a different extent based on the study we are looking at. So I know it's great, and as you showed a very older study from the Harvard study from 1960s. So I guess I'm trying to find out is, can we get a little bit more specific and break it down as to, in the Catalonia study, the fasting, I'm sorry, there's a little bit disturbance in the room, but the fasting glucose was impaired to begin with in all the groups, and it got worse by maybe 1 or 2 milligrams, so it did not improve. Secondly, also, you showed that the 2-hour glucose got better across the board, including the controls. So we know most of these studies, including the Indian Diabetes Prevention Program, had a greater impact on the impaired glucose tolerance when it was preventing the progression, and which makes sense because we think skeletal muscle is clearing, your postprandial sugar. So that is sort of just an observation. The question which comes now to mind is, were you able to pin it down to which exercise? The gentleman in the audience asked if swimming is better. So can we say which exercise worked best? Number two, can we say how many minutes as to a little bit more specific? And number three, if we can identify the pathways that are triggered by this exercise, is we may then better understand maybe even some other manipulations. Because in India, we have other things such as yoga, because, stress reduction, cortisol reduction also works. So socio-economic driven exercise also works way better. So those would be to understand mechanisms by which we are preventing diabetes. Is a big thing, but are we understanding what we are doing?
Okay, thank you very much for your question. So the results are showed like on the one you referred to was studied done in Colombia and South America and the north of South America. And you're right. I mean, we didn't see an impact on changes in fasting glucose. And as you mentioned, it has an impact on 2-hour glucose, which is also basically a stronger cardiovascular risk factor than fasting glucose values. And we are very rarely in fasting. Most of the time we're like postprandial because we're eating all the time. So in that say you ask about the styles of physicality. It depends. I mean, the discipline, for instance, in Barranquilla in Colombia, it's 35, 40 degrees, it's humid, so it's difficult. We cannot make them go and run outside. So what we had to adopt interventions, the physical intervention, local customs, culture, and traditions. And I think this probably you need to do everywhere. What we did for them, they like to dance. So we had a lot of interventions for dancing, motivated people, doing physicality later on during the day, maybe in public places, but it included a lot of like dancing and moving as something they like. In Finland, for instance, we cannot tell them going to run outside if it's 40 degrees below zero or 30 degrees zero in winter. So you need to adapt a bit the activity. Important is that you reach a moderate intensity level of physical activity, which is basically for the patients, we explain it, it's you can, when you practice it, you can talk still with your friend, but not sing anymore. So that's more or less moderate intensity as like a rule of thumbs for people. If you can't talk, then it's vigorous. But in regard the minutes, the recommendations, and most programs they included more or less 150 minutes per week of moderate intensity physical activity. Strength training, like 1 to 2 sessions or 2 sessions. I think with 60 minutes strength training per week, we're gonna do well according to the guidelines and evidence we have. So I think if you can tell everybody, try to reach 150 minutes of moderate intensity physical activity throughout the week, we're gonna be able to prevent a lot of diabetes. And the last one about the mechanisms, I could talk probably 1 hour about the mechanisms, and we could have to talk maybe next time, and how physicality impacts the whole physiology and pathophysiology and biochemistry in the body. But we have enough information how it impacts like platelet aggregation, how it activates, like how it has an impact on hypertension, on many other factors of the cardiometabolic circulation.
Thank you, Noel, for your inputs, and they are highly appreciated. And now I will move on to the next speaker, Dr. Elisabetta Petrono. And I will request the AV team to please display the introductory slide of Dr. Elisabetta. Welcome, Dr. Elisabetta. And Dr. Elisa is the immediate past chair of the Diabetes Epidemiology and Interest Group. Can we have the last slide, Dr. Elisa? Last slide was there. So I will go to the topic, and she will be talking about disparities in use of cardioprotective medications for type 2 diabetes. So now the floor is yours, and you can speak.
Wonderful. So thank you so much for this kind invitation today. I'm very honored to be attending this meeting, and with my colleagues, it's a pleasure. So I will take this opportunity today to talk, to focus a little bit on disparities in the use of cardioprotective medication for type 2 diabetes. So we are transitioning a little bit from diabetes prevention, which we have been focusing so far, to some of the aspects to consider once a patient is diagnosed with diabetes, and to try to, I would say, optimize as much as we can the care of these patients. So I've listed here my disclosures. This is the roadmap for today's discussion. So I will provide a quick overview on the recent advancements for diabetes type 2 in terms of pharmacotherapy. These are very meaningful because they prompted rapid changes in treatment guidelines for this condition. I will also briefly introduce the concept of pharmacoequity and its role in narrowing the existing health disparities. So a little bit touching on that too. And then I will share the, I would say, our experience and in our work related to the assessment of the use of novel diabetes medications in people with heart disease and obviously type 2 diabetes. We particularly focus on the racial, ethnic, and socioeconomic disparities to access these medications. Okay, so the pharmacological innovation in diabetes has been very rapid, as you can see, in the last, in particular, 15 years. Several classes of glucose-lowering medications have entered the market in this past 15 years or so. We see some of the major ones here, the DPP-4 inhibitors, SGLT2 inhibitors, GLP-1 receptor agonists, and also the very novel and new group of GLP-1 receptor agonists. Some of these agents, and we will focus in particular on SGLT2 inhibitors and GLP-1 receptor agonists today, have drastically changed the therapeutic landscape of the treatment for diabetes type 2. So a little bit of a brief overview on the existing evidence from RCT. So in recent placebo-controlled cardiovascular outcome trials, as we see here, this is a meta-analysis coming, point estimates coming from several meta-analyses actually. We see the SGLT2 inhibitors have shown beneficial effects in reducing the risk of several cardiorenal outcomes. So we see not only major adverse cardiovascular events, we see a decrease in risk and also of its components, but also hospitalization for heart failure. We see beneficial effects with respect to kidney outcomes, as well as all-cause mortality. Similarly, also for GLP-1 receptor agonist, the evidence from placebo-controlled cardiovascular outcome trials point towards similar reductions in major adverse cardiovascular events, as well as similar cardiorenal outcomes as previously discussed for SGLT2 inhibitors. So prompted by this very strong accumulating evidence, there has been really a shift in the treatment paradigm of diabetes type 2. So up to 2017, at least for the US, the ADA guidelines pretty equally recommended a variety of second-line options to control glucose in patients with type 2 diabetes, in addition to metformin, without any really strong consideration for the individual cardiorenal risk. Since 2018, however, fueled by these cardiovascular benefits demonstrated by these randomized control trials, guidelines have recommended the preferential use of SGLT2 inhibitors and GLP-1 receptor agonists in patients with type 2 diabetes and either atherosclerotic cardiovascular disease, heart failure, or chronic kidney disease. There is also some recent indication, at least from the ADA guidelines that from this year, to even consider these medications as first-line treatment for diabetes in patients with these conditions. I want now to take a step back and I think it's important at this point to introduce the concept of pharmacoequity. This is a field that is advanced by Dr. Etienne. We see here a very well-written viewpoint by him published in JAMA a couple of years ago. where he outlines very clearly what are the goals of pharmacoequity are, and specifically ensuring that all individuals, regardless of race and ethnicity, socioeconomic status, or availability of resources, have access to the highest quality medications required to manage their health needs. So in this goal, as we will discuss a little bit later on, is of tremendous importance in order to address the existing health disparities in diabetes, given in particular the critical and growing role of prescription medications in the management of diabetes and also other chronic diseases. So it has been shown that racial and ethnic minority population disproportionately experience higher prevalence and greater severity of chronic diseases. But the same populations are also more likely to have insufficient insurance or complete lack of insurance in the United States, and often report the highest rates of cost-related delays in care and lower access to high-quality medication therapy. For example, disparities have been reported in, we see here a couple of examples from a couple of studies in the use of novel medications and guideline concordant care in people with cardiovascular disease. So we see, for example, a recent study examining the use of different oral anticoagulants for people with atrial fibrillation, and found that Black and Hispanic individuals were less likely to use novel direct-acting oral anticoagulants, and instead very much more likely to use warfarin, an older treatment for atrial fibrillation, or no oral anticoagulation at all. Similarly, another study, which focused on a large cohort of people with heart failure, found that Hispanic individuals were less likely to use several key heart failure medications. We see, for example, ARNI, mineralocorticoid receptor agonist here, but also they were less likely to achieve a target dose of many other important cardiovascular medications and treatments, such as, for example, beta blockers. So with these examples in mind, we decided to conduct a study, and you probably recognize some names in these publications from today's panelists. So we sought to examine the current patterns of use of GLP-1 receptor agonists and SGLT2 inhibitors among a cohort of older adults with diabetes type 2 and incident cardiovascular disease. We wanted to in particularly focus on the potential racial, ethnic, and socioeconomic disparities in the access to these medications. So in order to conduct this study, we used data from Medicare fee-for-service between 2016 and 2019 in the United States. So Medicare is a US nationwide claims database of federally insured Americans, 65 years old and older, mostly, which includes information about diagnostic codes recorded during physician visits, hospital admissions, but also very detailed information with respect to medication fills. So our study population included older adults with type 2 diabetes who develop a new indication for GLP-1 receptor agonist or SGLT2 inhibitors use in the form of an incident atherosclerotic cardiovascular disease of heart failure. This was really our cohort entry day 0. We considered the information during the year prior to this cohort entry. So we excluded patients that had previously been exposed to either SGLT2 inhibitors or GLP-1 receptor agonists. We also excluded patients with kidney failure, some history of kidney failure at any point during the year before to cohort entry. And the ultimate goal of this population was really try to identify a subset of the US population for whom either SGLT2 inhibitors or GLP-1 receptor agonists would be universally recommended based on current guidelines, and without having, I would say, very strong contraindications, such as, for example, kidney failure that would prevent the use in particular of SGLT2 inhibitors. Oh, sorry. So our exposures of interest were race, ethnicity in particular, and zip code level social deprivation index. We assessed several covariates that we again measured during the 365 days before court entry. Those included demographics, including age, sex, region, year, comorbidities, so both metabolic, cardiovascular, claims-based frailty and comorbidity index. So those are indices that we use based on information collected in claims to measure burden of comorbidities and frailty in our population. We included information on other medication use as well as healthcare utilization measures, for example, physician visits, previous hospitalizations, and so forth. So the outcome of interest was to have received at least one field prescription for either GLP-1 receptor agonist or SGLT2 during, as we see here, the 180 days of court of follow-up after court entry. During this period, we calculated incidence rates for medication initiation for GLP-1 receptor agonists or SGLT2 inhibitors. And we fit Cox proportional hazards model with the idea of trying to quantify the association between race, ethnicity, and social deprivation index with the initiation of either one of these treatments. So we see that after having applied this inclusion and exclusion criteria, we identified over 4 million individuals who entered our cohort. This population had a mean age of approximately 75, 76 years. 51% approximately of individuals were women, and approximately 80% were non-Hispanic white. Before adjustment, we observed that novel medication initiators were overall younger and more likely to be men compared to non-initiators of either SGLT2 or GLP-1 receptor agonists. They were also less likely to be Black or African American. One striking aspect, and I'm going to touch on that also in the next slide, but as a starting point, it was that for a population for whom guidelines would, as we discussed, universally recommend these therapies, only 1.7% of individuals initiated either an SGLT2 or a GLP-1 receptor agonist during the follow-up. So we did notice, though, that there was increase in the use of SGLT2 inhibitors or GLP-1 receptor agonists during the study period. We see that between 2016 and 2019, the use almost doubled, I would say. But as previously noted, this was in the context of a very low rate of initiation overall. So after adjustment for the several covariates that we have, we measured before court entry, so including demographic characteristics, comorbidities, medication use, and healthcare utilization measures, we found that people who were older or female had a lower likelihood of initiating a novel therapy with SGLT2 or GLP-1 receptor agonist, as well as Black individuals and those of other race ethnicity. We also found there was a small but significant association between living in an area of higher socioeconomic deprivation in the US and lower rates of medication use. There were multiple medical factors that we explored and were associated with increased or decreased probability of receiving these agents. So for example, we see the cardiovascular risk factor indicative of early disease, for example, hypertension, NAFLD, obesity in general were associated with increased probability of receiving novel treatments. Whereas we found that markers of more advanced type of disease and disease severity were on the opposite associated with decreased probability of initiation. We also found a prior filling of medications used for treatment of atherosclerotic cardiovascular disease and heart failure, including beta blockers, ACE inhibitors, for example, was associated with higher rates and higher probability of receiving GLP-1 receptor agonists or SGLT2 inhibitors, whereas filling other first-line antihypertensive agents, for example, more commonly used for, I would say, uncomplicated hypertension, and so not really per guideline in this population, were associated with less likelihood of receiving these novel treatments. Again, we found that the diabetes microvascular complications and the use of additional diabetes medications were associated with increased likelihood for receiving these novel agents. And finally, in terms of healthcare utilization, we found that to receive care by a specialist increased the likelihood of, again, receiving novel treatment, whereas instead having a recent history of an emergency room visit or hospital admissions was decreasing the likelihood of receiving these novel agents. We performed a few subgroup analyses. Here we see results in analysis stratified by indication. So specifically, we divided the population by atherosclerotic cardiovascular disease indication and heart failure. We found as a starting point that the incidence rate for initiation of these novel agents was higher among patients with atherosclerotic cardiovascular disease compared to patients with heart failure at baseline. We also found that overall, the racial and ethnic and socioeconomic disparities we observed in the primary analysis persisted also in this stratified analysis. In analysis stratified by year, we again confirmed that racial, ethnic, and socioeconomic disparities also persisted for all years of study from 2016 to 2019, with some evidence of a decreasing trend in the degree of disparity over time among non-Hispanic, Black, and other race individuals. So these findings have been replicated in several studies at this point in time based on claims registered in EHR conducted in the United States as well in Europe mostly. These studies have confirmed the low rate overall for the use of this novel treatment, SGLT2 inhibitors and GLP-1 receptor agonists, as well as the presence of differences in the access to these agents for racial and ethnic minorities and for individuals with socioeconomic deprivation with and without cardiovascular indications. Some of these studies have also confirmed that individuals with cardiorenal indications who we would expect would be the ones that would receive the greatest benefit in being treated with these agents are generally less likely to receive therapy with these novel agents. So along these lines, a study wanted to quantify the consequences of missed treatment with a GLP-1 receptor agonist or SGLT2 inhibitors, and wanted to specifically estimate the number of preventable MACE events, so major adverse cardiovascular event outcomes, if all patients, hypothetically, were treated with guideline-directed care with respect to three medication of classes of interest, let's say. So they focus on high-intensity statins, ACE inhibitors and ARBs, and GLP-1 receptor agonists or SGLT2 inhibitors. As we see here, the authors used information from over 150,000 commercially insured adults with type 2 diabetes and atherosclerotic cardiovascular disease. And we see that they found that only 2.7% of the treated individuals, so of the individuals included in the study, were really treated with all three of these, I would say, treatments that the authors wanted to assess. And among the three treatments, they found that GLP-1 receptor agonist or SGLT2 inhibitors therapy was the most underused of the three, and therefore had the greatest potential for absolute risk reduction over 3 years. The author specifically quantified this potential for risk reduction as the potential of, I would say, preventing up to 2,200 MACE events had this patient been treated with these agents 100% for 100% over a 3-year period. So in conclusion, so we see that there are significant racial, ethnic, and socioeconomic disparities in the use of diabetes medications with proven cardiovascular benefits. And this is true also in populations with strong indications for treatment with these agents. Because of the established benefits from RCTs of these classes of medications, these disparities in use will translate into disparities in clinical outcomes. And we have seen some attempt for quantification in this regard based on the study I've just discussed. It is exactly in this context that improving pharmacoequity can represent a meaningful step towards decreasing health disparities. So with this, I thank you everyone for the kind attention, and a special acknowledgement to my co-investigator, in particular to Dr. Sarah Cromer, who led this work and who is also one of our panelists today. So thank you so much, everyone. I'm very happy to answer questions.
Thank you, Dr. Elisabetta. And I think you have highlighted it very well, that we need to address the disparities which exist in pharmacotherapy of our patients. And now we know that there is a good evidence that supports the use of GLP-1 and the SGLT2 inhibitors, especially in people who are at the risk of cardiovascular disease as well as the renal disease. And disparities do exist. This is also a reality. But I think US is doing a lot. Now the cost of insulin is coming down. Soon we can see the cost of GLP-1 and the other medications coming down too. And only with and more insurance, I think more and more people, if they are covered by the insurance, these things can be covered easily. So I just had a comment, but not a question. We have, I think it is 9 p.m., around 9 p.m. in India, and it is middle of the day in US. I would like to thank you on behalf of the entire team of the Diabetes India, Dr. Bansi Sabu, Dr. S.R. Arvind, myself, and to the, can we have, is Noel still there? Yes.
Yeah, I'm still here.
Noel is still there. So can we have the gallery view here? Yes. So we have, thank you, Noel, for still being here with us till the end of the webinar. And just final concluding remark from the ADA, from you and as well as Dr. Elizabeth.
Good. First of all, thank you, Diabetes India, for this opportunity. I think we have heard 4 interesting presentations, and there's still a long way to go how to implement our research findings in general, in order to, for the benefit of the population, to prevent or delay type 2 diabetes, or how to prevent complications in patients with type 2 diabetes. And I think a lot of focus should be done on that translational research component and the dissemination of findings. From my point, I really, with all my heart, thank you so much, India, for hosting us virtually. I hope maybe next year we can meet in person. It will be really, really nice. Thank you very much. And thanks to Amit for organizing.
We would like to have all of you next year. The meeting is in Bhubaneswar, India, and this is going to be in the month of January. And it would be our pleasure to have you here in person, talking to the Diabetes India and bringing ADA and Diabetes India together. So thank you once again for this collaboration. And with this, I would like to conclude this session. Thank you, Sarah. Thank you, Sarina. And thank you, Dr. Elizabeth, for your deliberations as well as this important association. Thank you.
Thank you, everyone.
Thank you.
Thank you. Bye.
Bye-bye.